Hello and good afternoon, everyone. Thank you so much for joining us. Today is Leap Day, so happy Leap Day to everyone. We only have this day every 4 years, but nevertheless, my name is Jessica Zavala, and it is my pleasure, on behalf of the Ohio Program for Campus Safety and Mental Health, to welcome you to today's webinar, Eating Disorders and Body Positivity on Campus. And I will turn it over to Madison to share a few additional announcements.
Hello, everyone. My name is Madison Gaskill. And before I introduce our presenter for today, I do have a few announcements that I would like to share with everyone. So for today's presentation, we do have CME and CEU credits available. The activity code for today's session is 87LAIR. That's 87LAIR. We'll put that in the chat as well. That code will expire tomorrow, Friday, March 1st at noon. So make sure you get in there and get your credits before then when it expires. Next, we would like to invite you to March's webinar next month, Wednesday, March 20th. 2024 at noon as well. Join us for a panel to discuss sexploitation and intimate partner violence on college campuses. We'll be joined by Julius Payne from Kent State University, Molly O'Malley, a Neomed Title IX consultant, and Erica Butler from The Ohio State University as well. So hope to have you join us next month as well. Additionally, we are excited to share that registration is now open for our inaugural Campus Safety and Suicide Prevention Symposium on cultivating caring campuses. The symposium will be hosted at Northeast Ohio Medical University here in Rootstown, Ohio, coming up on April 11th of 2024 this year. The day will run from 8 a.m. to 2:15 p.m. And also wanted to share that directly following the symposium, we'll be hosting a free screening and discussion of the S-Word film. The S-Word is a powerful documentary that puts a human face on a topic that has been long stigmatized and buried with the lives that it has claimed. So we're looking forward to having a discussion moderated by Lisa Klein, the director of the S-Word film. And that discussion and screening will be from 2:15 to 3:45. And that is open to all students, staff, and faculty at all universities and community organizations. You can find additional details on the symposium and other events coming up on our website and our social media pages. So feel free to check them out there, and we hope to see you soon. Alrighty, and as we move forward with our webinar for today, we encourage you to post any questions or comments in the Q&A and chat function, as we will save some time at the end of the presentation to address those questions. And last thing here is the webinar is being recorded and will be available for viewing on our YouTube channel. So for future reference, you can check it out there. But without further ado, I am happy to introduce our presenter, Dr. Kate Adkins. And I will pass it over to Dr. Adkins to introduce herself and share more on her expertise on working with eating disorders on college campuses.
Thank you, Madison and Jessica. I'm excited to be here today. I am going to be talking about eating disorders and body image on college campuses. And I'm excited, especially today, because it is National Eating Disorder Awareness Week. So perfect timing to be able to discuss this very important topic. If you could share in the chat your experience working with eating disorders, if you're very experienced, somewhat experienced, and what type of practitioner or campus staff member you are, that'll help me adjust a bit of my comments and lecture today. So eating disorders and body image. I am going to share experience I've accumulated working with the eating disorder population over the last 10, 15 years. I have an interesting, kind of unique array of experience that includes working at outpatient mental health centers, hospital agencies, as well as eating disorder specific IOP and partial hospitalization program. There's a good amount of overlap between eating disorders and some personality disorders or heightened emotional stunting or awareness. And I've been intensively trained in DBT as well, and that has been a wonderful adjunct to working with this population. Currently, I'm in Worcester in a private practice where I'm raising my family, and you'll see here a picture. This picture is on request to have a picture of my therapy dog, Chloe, here. So she's in the office with me most days, not today. She's not an on-camera dog, uh, but there is a lot of fun. She interacts really well with clients, loves teens and kids, and it's fun to break up some of the seriousness of this work with her in the office. So jumping into eating disorder treatment, we're going to talk a little bit about the significance of eating disorders and the severity, diagnoses, assessment, and treatment. Then we're going to talk about body image, and what's really important are the campus resources and teams, ideas for being able to serve the college student population, improving access to care, as well as trained eating disorder professionals for the students. So eating disorders are commonly seen as kind of a worried well population, people who've maybe taken dieting too far. But the reality is that eating disorders, especially anorexia, and especially paired with depression, have the highest rates of suicide. There's a significant medical complication to eating disorders, and their both short-term and long-term health. There's a great deal of life disruption with active eating disorders. So the lifetime prevalence is 9%, as many as 41.5% of females athletes report disordered eating and are more likely to incur injuries. A lot of overlap between eating disorders, like I said, and depression, leading to a higher likelihood of death by suicide. Students with eating disorders also experience the stunting of their socialization, their dating, loss of healthy normative college experiences. They oftentimes do have to be removed from campus to access higher levels of care and interrupt their collegiate journey. So good reason for us to discuss this population. So I mentioned these medical complications. I'm not going to talk a lot today about a whole lot about medical complications, but the general list across all eating disorders you can find here of acute medical complications, long-term, and mental health complications. So if you're not familiar with a few of these terms, we do see with restrictive eating disorders like anorexia, bradycardia is common, and that is a slow heart rate. Hypotension is the difficulty of the body's normal systems to, when malnourished, to manage changes in blood pressure. This can lead to syncope or fainting or near syncope. And interestingly, the biggest reason for ER visits with individuals with anorexia is actually head trauma due to fainting. Oftentimes this happens in the shower when there's changes in pressure with all of the medical systems, steam, heat, lightheadedness. This can happen though with sports oftentimes, even on college campuses after a cross-country meet, athletes passing out after soccer games, any sport. So the fainting is a significant problem. Oftentimes there's a good deal of gastrointestinal distress, whether that's bloating, gas, constipation, diarrhea, a lot of problems and sensitivities as a result. And in fact, after someone who has a restrictive eating disorder starts to refeed, they can experience something called delayed gastric emptying, where they are over full and their system is not able to catch up fast enough. Which is very distressing. Esophageal tears, cardiac arrhythmias, rectal prolapse are medical complications due to bulimia and overuse of laxatives and diet pills. There's also low bone density. So females will gain bone density, build bone density through calcium intake through 22 or 25, and then we start to lose it. So when we're not getting adequate nutrition, we're not able to kind of meet that threshold, and we have a lot of problems with bone density, fractures, hairline fractures. So there's just a good amount of medical complications. And mental health complications, there's a good overlap of anxiety disorders, especially generalized anxiety and OCD often, sometimes phobias, sometimes eating disorders are triggered by phobias of choking or throwing up or food allergies, things like that. And then the restriction continues until the individual is eating a significantly low amount of nutrition. So pretty significant, a lot of overlap, and a lot of high medical severity with this population. I want to run through a few of the diagnoses for you. The main four. This is a very much an overview lecture, so there's a lot of information that we can't delve into. So I wanted to talk about anorexia, bulimia, binge eating disorder, excuse me, and ARFID, which is a new diagnosis in the last several years. So anorexia is typically well known as a restrictive eating disorder with significant weight loss and impact of medical functioning. Excuse me. So there is a fear of weight gain, but the restriction is the primary behavior with anorexia. There is interesting and compelling as a diagnosis different than others is that individuals with anorexia, like the picture shows here, often experience a great deal of body dysmorphia. So there's actual disturbance in the way that they see their body. And it's hard to explain what this means other than you see fat when there has been significant loss. Kind of a visual disturbance. This is really hard in treatment as well, because the reality when someone is refeeding and regaining weight loss, they are incredibly hyperfixated on the weight gain as fat, even when it's normal and necessary, and when they're still malnourished and significantly underweight. So refeeding is really difficult for this population. There can be binge eating and purging under the diagnosis of anorexia if there's restriction. And the severity level is based on BMI. And what's important to notice about the BMI is that it's often used as cutoff points for higher levels of care. So below 16 or 17 is often inpatient or residential. And then, it's harder to have coverage of residential treatment if someone's at a healthy weight based on their diagnoses. The concern with BMI is important to note, but that's at the top end where people can have a higher than normal over 25 BMI, but still be incredibly healthy, especially if they have higher muscle mass. There aren't concerns at these lower levels. And under 17 is very difficult for anyone with a restrictive eating disorder to not experience the symptoms of malnutrition, like cold intolerance, amenorrhea for women, GI distress, and a lot of the others. There's a great deal of overlap with anorexia and OCD, very over-controlled population. So their dial is too far on the end of doing too much to manage anxiety. And with bulimia, there's a bit of a flip between over-control and under-control. So bulimia includes recurrent episodes of binge eating with compensatory behaviors, whether that's vomiting, misuse of laxatives or diuretics, or over-exercising. Body image is a concern for all of these diagnoses. Can trigger eating disorders, the negative body image, but you'll see that treatment does not include as a primary focus managing body image. But it's a kind of you'll see those threads woven throughout this population, the diagnoses and treatment as well. Severity measured by the number of episodes per week. A great deal of overlap with depression diagnoses with this population. And ARFID, this is avoidant restrictive food intake disorder. This is the disorder that previously was wrapped under this eating disorder not otherwise specified diagnosis. And research has really separated this out, helped a separate diagnosis, because these individuals look very different than other eating disorder populations. They tend to have restrictive eating and low weight because of the avoidance and restrictive diets, but they are not eating the healthy foods like vegetables, and they're not afraid of the high-fat food. It's often the opposite, where they struggle with some texture issues and tend to eat a lot of fats and carbs. Often do have significant weight loss and nutritional deficiency. These individuals can require tube feeding as well. Oftentimes this is diagnosed in childhood, but not always. And significant overlap with both anxiety and depression. The treatments for ARFID look like a cross between the behavioral treatments, especially for adolescents, the behavioral treatments that we have, and exposure-based treatments like we have with binge eating and anorexia. And then binge eating disorder is a binge episode is really a significantly larger amount of food than a typical person would eat in a setting, and a lack of control of eating that food. So this is not eating maybe a slightly larger meal, but this is something that's causing a great deal of distress, total loss of control. And people will say that they feel like Cookie Monster, just kind of like shoveling in as much as they can. So oftentimes people will be eating more rapidly until they're uncomfortably full. They'll eat large amounts when they're not physically hungry. There's a great deal of disgust, embarrassment, and shame associated with binge eating. And there's no compensatory behaviors. Otherwise, this would meet criteria for bulimia. So these individuals do tend to be overweight or struggle managing a healthy weight at the very least. So when we're talking about treating eating disorders on college campuses and even identifying, a lot of this is internalized. Internalized anxiety, over control with secretive nature, making excuses for eating, trying to manage behavior so that others can't see that you are losing weight or not eating. Also, or the under control portion comes with a significant amount of guilt and shame that are often not shared with individuals on campus who could be supports or help access treatment. So it can be difficult to identify eating disorders on a college campus, especially with just the private nature of residence halls and or private rooms. And a lot of, this is a stage where kids are very independent. So assessment tools clinically for my mental health therapists are going to be the ED-15 is a big one. I've been using this a lot lately. All of these you can access pretty easily. For those that are more in depth and provide more information are the EDQ and the Eating Health History Questionnaire. That's a really great one for identifying eating disorders. This fourth one on the list here, the EHQ, a lot of a 3-page assessment with a lot of fill in the blank summary answers about the history of eating behaviors. when we're talking about restrictive eating disorders and this over control, there's a great amount of preoccupation, obsessions, and this is intensified by the effect psychologically on the brain of malnutrition. We do know a great amount of research demonstrating that a malnourished individual develops anxiety, obsessive behaviors around food, dieting, physical exercise, eating. So when we're talking about malnutrition, there is, often accompanying like OCD type feature that serves as a barrier to refeeding and recovery. So I've started also using Y-Box. There's some literature that demonstrates that restrictive eating is a form of obsessive compulsive disorder in its avoidance. So whereas someone with hand washing would be super anxious about not being able to wash hands another time, and they reduce that by acting on it in hand washing. Someone with high anxiety about a fear of becoming fat and not wanting to eat the food would reduce the anxiety by avoiding the food. There's a great deal of overlap with my ED-15 scores and the Y-Box. And I think that it's the most helpful to note for individuals working with restrictive eating disorders that it's not a choice. It's a very, very difficult and severe type of OCD. There is a screening tool for physicians. This is a very quick 5-question tool that the physician can pull up, perhaps give the patient some privacy to answer the questions, and they'll say 2 out of 5 questions were positive, refer to a clinician. So treatments for clinicians, if you're a licensed clinician, the main treatments are these top 2 I've underlined. These are evidence-based treatments. The first is a family-based treatment where you involve the parents. The parents are in the driver's seat. We use this with adolescents mostly, but sometimes your college students are going to be arriving on campus with conditions their parents have set up, or guardians with regard to maintaining weight, having access to a treatment team already to be able to make sure the student can adequately nourish away from home. The primary treatment for adults is CBTE, an adaptation of CBT by Christopher Fairburn out of England, who has it's a very adult type of treatment that an individual needs motivation in order to engage in. There's weighing and food logging, and those are really high anxiety provoking situations for people with eating disorders. So, but it's really great treatment, something that is able to be implemented at college counseling centers as long as you have access to 8 or 10 visits. There are other treatments, just to list some here for some of these other diagnoses. So there's newly coming out treatments for ARFID, and for those with non-underweight patients there, where you don't have to focus on food, but or I should say, you don't have to significantly focus on stopping and reversing weight loss and malnutrition. You really can focus on normalizing eating habits, less of a medical coordination of treatment. There's also temperament-based therapy with support. This is Laura Hill's group at what used to be the Center for Balanced Living in Columbus and is now a part of the Emily program. This work by Dr. Hill and her colleagues examines the way that the brain functions as a result of with different mental health diagnoses, namely eating disorders. And there are difficulties in many different centers of the brain. And then you can adjunct your treatment. I use a lot of the DBT interventions, a lot of ACT interventions and interpersonal therapy. These do not have evidence-based treatments in and of themselves to treat the primary symptoms of these disorders, but we kind of whatever we can do to help our clients. And if you can draw from other perspective with an integrative approach, your clients will benefit. So I do want to talk about body image before we talk about all the campus resources that could be useful. So body image just is mostly a result of or related to disruption of healthy body expectations with the thin ideal. So we see eating disorders across all cultures, all populations, but especially those where the thin ideal is valued. We see this in a few other cultural populations. So Asian populations tend to really highly value smaller body size. Also, higher prevalence with in the gay male population, and any populations, careers, or avocations where body image and appearance ideals are important. So modeling, singing, dancing, even public speaking, and, as well as sports and organizations. Like on college campus, you would see dancers, gymnasts, figure skaters, related to body image. So, and it's very prevalent. There are a lot of mixed messages in culture and society about like being healthy and doing, what you need to take care of your body, but also weight loss is always touted as the goal. Is rarely like, let's work on gaining some, you don't see these social media messages of like, let's all work on gaining weight this year. Those are not New Year's resolutions. So by and large, the thin ideal is really shaping culture, where we're not really normalizing healthy bodies that change over time. So across eating disorders, body image can be a trigger, but is rarely the first intervention in treatment. So if negative body image is affecting eating, normally we normalize eating patterns pretty quickly before they become medical issues. And we're working on body image as well. Also, sometimes body image is not associated with the cause of an eating disorder. Sometimes it is I see often, we're in the Catholic Lent season, so we see people giving up sweets for Lent, and then they're successful, and that fuels a desire to see if they can cut out more, until eventually they're malnourished. This happens a lot with fasting, with religious associations, but also with just trying to cut weight for sports, wrestling, for example, also to improve swimming and running scores, so track, cross country, and swimmers. So a lot of times body image is not a direct cause. On that note, there's also a lot of trigger of someone who has OCD tendencies that happens to see maybe the obesity lecture or video in a health class, and that triggers kind of the onset of symptoms that lead to an eating disorder. So, really body image isn't something, and this is a stereotype, right? That you just want to be skinny or you just want to look good, or this is a very vain type of mental health disorder, but really, really not the case. If we're talking about restrictive eating disorders, when we're refeeding, when we're working in recovery, the first several stages do not include body image work. And we know that when we try to focus on body image or go back to the root of the trigger for the eating disorder, that we're not effective at changing eating habits through body image related insight. So for eating disorders, we're really not focusing on body image at the start, at the outset. But it is a part of work. We assume that it is kind of a later stage work for restrictive eaters, and it can be woven throughout work based on the intensity of the impact or preoccupation for anyone with an eating disorder. I will say, though, that a good deal of individuals with eating disorders do not have the willingness to do body image work. Oftentimes they are afraid of giving up the thin ideal, and they'll do work until their, disordered eating is managed better, and then not be willing to challenge their negative body image. So that's important to know that, body image is important, but we don't always get to it in treatment. It's not always necessary in eating disorder treatment to prioritize, and individuals, college students, need to be actually willing to do the work. I want to talk about a really cool, doing body image treatment work is important and can be incredibly empowering, especially with preventing future relapse from eating disorders. So very, very, very important to do. On a college campus, there are some cool projects that can help students, even who don't have eating disorders. And the Body Project is the main program. This is a student-led prevention program. It's a short 4-week program, a small group of 8 to 10 individuals that discuss issues with regard to negative body image, its origins, how we take care of ourselves. There's an intervention that includes writing a letter to your body, apologizing if you've mistreated it or not appreciated it, expressing appreciation for functionality. So building strength as an importance, especially if you're an athlete, as opposed to being upset that your thighs are too big or your, whatever other body struggle that you have. And this program does reduce body dissatisfaction, negative moods, unhealthy dieting, and disordered eating on college campuses. This can be adopted by any type of group, whether it's through student wellness. It's often funneled through Greek life, through sororities, but anybody can pick it up. You can have multiple body projects on campus. This is something that an individual would have to sign up for. And it's not recommended that college students engage in this type of program if they have an active eating disorder, because that's going to be much more intense and require more professional intervention than the Body Project can provide. And that the trainers that lead this program, if they've had an eating disorder, have been in recovery for at least 2 years. And you can easily find this flyer through NEDA if you'd like to consider implementing the Body Project on your campus. It's really easy to sign up. The training is not rocket science. It's really interesting. The small group dynamics can be really beautiful as well. I would say the main difficulty of implementing this is just scheduling with college students and their various, clubs, organizations, sports, and academic programs, of course. So if you're in a position on a college campus, your questions are going to be around how to identify students, and then what resources do we have once we identify students. So some warning signs often are seen by coaches, roommates, and in residence halls where you tend to be around more of the private domain for students. These include weight loss or gain, especially in short periods of time, isolation, withdrawal, changes in mood and functioning, going out a lot with friends fall semester and suddenly, a lot of excuses, never going out, things like this, changes in diet, and eating behaviors that perhaps roommates can recognize. Anxiety, panic, loss of periods. So medical college, health centers on campus, if you've got students coming in with recurrent issues of this type, you might assess for an eating disorder, asking about malnutrition. We'll also say that there's a great deal of food insecurity across college campuses. Most campuses have access to some sort of food pantry, if that's the case. So, that could be a life situation that causes loss of nutrition for students. Yeah, especially fainting of college students is a big red flag. People with eating disorders make a lot of excuses. I already ate. They've always already ate when they go to Taco Tuesday, or don't go to the dining hall more than a couple times a week. They're in the bathroom a lot, or they leave the bathroom right away when others use the bathroom, or only use private bathrooms. There's a great deal, by the way, with college students of bathroom insecurity, having to use the restroom when others can be in and out and present. So there's a good deal of bathroom anxiety across the board on college campuses. Picking out or hiding food, that happens a lot more when someone is watching you, an individual with an eating disorder, eat, less so on college campuses than these others. And then once students are identified, there are a lot of resources, a lot more resources for college students on campus, I believe, than one can often find in their community as an adult. So there's campus counseling centers with trained therapists. The gold standard is an eating disorder treatment team on campus where a mental health professional leads or supervises eating disorder counseling and or runs eating disorder group therapy and collaborates with dietitians and an identified physician at the student health center. And this helps kind of try to funnel these identified students to professionals who have this experience and gain this experience and work really well together. There's often a space of collaboration once a week or once a month where they sit down and create time, prioritize time to address these students. In all of those settings, so the counseling settings, there's a great deal. There's individual counseling, group counseling, often access to psychiatric services. I'm not going to really speak to medication today, and I'm not a prescriber. I could answer a few questions about it, but generally there should be a prescriber on campus, either at student health or psychiatry or in the counseling center. I have the website for NEDA here, the National Eating Disorder Association. There are amazing resources on this site. Also on campus, disability services or student advocacy services, whatever it's called on your campus, these individuals will often need to help with your care and treatment, whether that be helping to orchestrate special needs, what are they called, delays in or like extra time for assignments, excusing absences from medical or counseling appointments, oftentimes also helping to try to continue to be successful for a student to continue to be successful if they have to step away from campus, take a long period of time off, and act kind of as your FMLA coordinator for a student's academic experience. They can be very, very useful, and they often know all of the interventions, accommodations, and can help link with other services on campus. Large universities are able to have eating disorder experts in their counseling centers and student wellness centers, even their dietitians. But the smaller campuses tend to have to work and rely a lot more with the outside community to find outpatient therapists, coordinate with insurance, transportation, with family, oftentimes, and parents, and physicians who are trained to treat eating disorders. And I say trained because there are, we all inherently have this weight bias. Dietitians I've worked with will say, like, I had to learn on the job that I was saying things, making comments that could be misconstrued, that suggested, like, good for you if people lose weight is not an appropriate response. And just to be sensitive to issues of an awareness of good foods versus bad foods, what eating disorders look like, how they can present, and appropriate treatments and interventions. We can sometimes do harm if we don't kind of check our bias, and this happens with the eating disorder population, unfortunately. I will say a note here, a special note about international students. They often struggle with a great deal of stress and anxiety. They don't have family supports available locally, And they're restricted a good deal because they are often not allowed to work, earn money, have driver's license, or have access to transportation. And they almost always have student health insurance, which can limit their off-campus options. So these are a group of students that we have to be cautious with our referrals off campus because they often don't have the ability to access off-campus resources. Yeah, and there are many others. Sometimes Greek Life has body image days. There is a group at Ohio State in an academic department that runs a body image fair with a lot of really good and helpful information. Speakers on campus, a lot of fun groups and activities just based on the staff and their areas of expertise and interests on campus or requests. So resources I have for you guys for clinicians, the assessment screening tools, the eating disorder treatments, manuals of the family-based approach. This is, and I'm a visual learner, so I always have books. Oh, that's right, I have my blurring on, so I won't hold up anymore, but Chris Fairburn has a couple of really good books. And hopefully you should have received or you will receive a reading list highlighted for clinicians if you of these resources. If you're not familiar with eating disorder treatments, evidence-based treatments, I always recommend you should know what they are, what they say, why we weigh patients for exposure therapy. So you can take a look at that list. I always encourage clinicians to have knowledge of health at every size to really challenge weight bias. It is not an eating disorder treatment on its own, but very, very important information. Body image treatments, I recommend the Positive Body Image Workbook by Nicole Wood Barklow, Tracy Tilka, and I'm blanking on the third author. I'm looking at my bookshelf at the third author, but that's on the reading list for you. And trying to coordinate with treatment professionals on or off campus as you can. For those in leadership positions or student life positions, be aware of your counseling centers, the treatments that they offer, help coordinate with families if needed. Having trained professionals trained in eating disorders is a must. And then again, the NEDA website for you. And so I think I've almost stayed on time here. Just barely with 1 minute, just in time. Looking at some of these questions to see if I can answer. Great. I don't have any questions on this chat list. What do you have for me?
Yeah, I can share. It looks like in the chat, one of the questions was, or the Q&A was, what might group therapy look like in conjunction with individual therapy approaches?
Great question. We're very cautious when we recommend group treatment, mostly due to the high severity of comparisons. Eating disorders are very comparison-based. Trying to think how to say this most succinctly. So if you have an individual that struggles with the comparisons, or is telling you that they're doing really well, but then they sat next to this girl in class who was looked like she was super sick with an eating disorder, and that triggered, right? Like didn't eat the next meal, then that's an individual that wouldn't be appropriate for group. And so that's kind of the threshold that I use for adding someone to group therapy. If they're just looking for more support, extra resources on campus, and shared experience, but that they don't have that significant level of preoccupation and comparison. The topics are going to include food, body image, things of that nature. And it's difficult to control those messages in groups sometimes. Yeah. So at Ohio State, we had a couple eating disorder support groups, and we would recommend that for students who were looking for some more resources, or we couldn't see them with the frequency that they would like. So we used the mostly body image group, eating disorder groups as an adjunct to individual treatment. And we were in a great, again, a large school. There were 3 or 4 of us who specialized in eating disorders. We had 2 or 3, maybe 4 at times, different groups running. So if you're in that position, you could certainly adjunct or complement your individual treatment with the group work.
And we did have another question from Lisa as well, who asked and mentioned that there are a lot of great trainings in suicidal ideation and how to ask specific questions to determine the risks and seek help. And she's wondering if there are similar tools for in the school to help identify students who might have an eating disorder.
The assessment tools will be useful. Those are really, especially the EHHQ, are really gathering information about behavior. So if you're looking for life-threatening risk with regard to restrictive eating or binge eating or bulimia, you're really going to be asking about severity and frequency of all the behaviors. That's a great question, though, because clinically, I just have my own questions. I have, my own list of eating disorder questions that I ask, relevant, not relevant, talking about assessing about physical symptoms like, constipation, cold intolerance, GI upset, food history. I do a food recall. What did you eat yesterday? What's everything you ate today? Ask about counting calories. If so, how many? Just kind of, those assessment tools have great questions. And probably everything that I ask, I take from those in my general, assessment interview. I focus a lot on assessing level of care at the outset. Do you need to go? I mean, this is a big one. If people are talking about fainting, or if I ask, have you had any fainting, or do you feel lightheaded? I had a parent over the phone that told me their 17-year-old had passed out after a sporting event. And I said, we scheduled, but I encouraged them to actually go to their doctor or the emergency room, and they were admitted immediately for bradycardia for 11 days. So I'm asking about those. I mean, kind of not really an extreme case, but those quite, you don't want to start doing outpatient treatment with someone who is so severe, they are going to be, they're more appropriate for a hospital setting. Yeah, so I'm assessing for appropriateness in outpatient at that point in time. I saw another question about orthorexia. So orthorexia is this, so those of you who aren't aware, it's this idea of, this was a term coined by a male physician. There's kind of anorexia for men, but without body image, without fears of being fat, solely focused, looks just like anorexia behaviorally, but it's focused not on fears of weight gain, but of restricting food based on clean eating, organic eating, and kind of a superiority of managing every little thing you put in your body. And I will say that sometimes eating disorders present this way. Yes. And they look and act just like restrictive eating, anorexia, and the treatment is also exactly the same. This over control, fear of eating something that's been processed or is not organic or is not clean or is a fast food item. So a question that can be helpful is, would you go through McDonald's drive-through and order a water? And if you did, would you drink it? And often the answer is no. They're really highlighting, there's a lot more to that than water. And then I'm looking at this too. Sex differences between men and women. Let's see. So 10% of individuals diagnosed with anorexia are men. It's a smaller portion. Stigma is often a barrier to identifying and accessing treatment. I often see a lot of men presenting with restrictive eating who have more of an OCD typology than a body image typology. There's something called bigorexia, which is men taking steroids to be, just like we have the thin ideal, there is this big ideal that the average man believes that heterosexually women are most attracted to a man who is the size of an NFL linebacker muscularly, which is not that's not accurate to what women actually report desiring. So it's kind of like this thin ideal and this bigorexia that my colleagues call it. So we see a lot of this as well. This is another piece with taking hormones and testosterone and that cuts your lifespan short. So we see a lot of that. A lot of binge eating, higher percentages of binge eating with men than anorexia, if that helps. Yeah. And to go back to the question about orthorexia and I'm sorry, I didn't address the piece about how would you treat those individuals. I would do treatment in the same way and give my education to that client being the over control and how it's perpetuating a fear of something that can't actually hurt you. And like balance. I'm very much about balance. It's all like, okay, it's, this is about balance. So we can disagree on the semantics, but we can agree that the nutrition is out of balance. So I would just, meet them where they are, not have to put a label or a diagnosis on it if you don't have to. Yeah, and orthorexia is not recognized as a ICD-10 or a DSM-5 diagnosis.
Anybody else have questions for Dr. Adkins here?
I do see one in the web chat. If students have an eating disorder and BMI is less than 16 and they refuse to get treatment, at what level are they considered a danger to themselves? And how do we, as physicians, help a patient that refuses help? This is so tough because parents can force treatment against a child's will if they're a minor. We can't do that in adulthood. So if you're a physician on a campus at a student health center, what I've had happen in the past is that the physician refuses to work with a student, unless they get treatment. And that's not ideal. A lot of times what we do is express concern, ask if there are other people involved, partner, fiance, husband, wife, or parents, and engage the stakeholders. Oftentimes, they are unaware of the severity of the eating disorder. And that can be useful. To be honest, I've never been in a situation where we have pink slipped for anorexia or medical. We're talking about low BMI, so anorexia, where someone was, not a willing participant in either an evaluation or a trip to the ER. That would be something. So I can't speak to that. That would be, but also they can refuse treatment if they were, the ER doc wants to admit someone, they can refuse to be admitted. What you're really talking about is having a loved one go through court channels to access a medical power of attorney. And that's actually really surprising. That's really rare. On a college campus, I can't imagine they're being successful. Yeah, so that's really, really tough. I would say being open for someone returning, contacting, I'm not sure what, so you're bound by HIPAA most likely, not FERPA, so you're still stuck with regard to sharing medical information for an adult with someone, with someone they haven't given you permission to share with. So you're really just asking them to return when they need to use emergency resources, go to the ER, talk to their family doc, and engage with those family resources. It's really adolescence can be difficult, but at the very least, we have avenues to pursue safety when needed with their parents. And it's really hard when you've got such a young person in that spot. You're really relying on motivation to treatment. Yeah, it's tough. Good questions.
Well, it appears as though there are no final questions. And Dr. Atkins, I just want to say thank you for such a very informative presentation. For those of you who are claiming CME, CEUs today, that code is one last time, 87LAIR. That's 87LAIR. And we hope to see you all again at our webinar next month on the 20th, as well as on April 11th for the Campus Safety and Suicide Prevention Summit. Thank you again, everyone, and have a wonderful afternoon.